Hi, my name is Zachary Town, and today as part of the health equity curriculum, we're going to discuss diet and weight management. So the objectives of this lesson, including the other resources, are to learn and describe the health risks of obesity, describe the term body mass index and how it's calculated, describe the current nutrition guidance for patients, list some diet options that are available to the patients, pros and cons, and then demonstrate nutrition counseling skills. So before we discuss dieting and weight management, I thought it was important to go over the health risks of obesity. Obesity has been described as a disease, a comorbidity for other diseases, a risk factor for other diseases, and an epidemic within the United States. And so I thought I'd highlight that 300,000 annual deaths are attributed to overweight and obese conditions. 80% of those have had a BMI over 30, which we'll go over. And we've seen increasing rates of mortality with increasing BMI when over 30 plus. The Framingham Heart Study, which is a long-running analysis out of Framingham, Massachusetts, noted that 40-year-old women lost 7.1 years of their life, effectively having their life expectancies being 7.1 years shorter, and for men, it was 5.8 when obese at 40 years old. I thought I'd also point out this graph, which is the average weight for the American man and woman from the 60s to 2010. So as we know, it's an overall upward trajectory. Since the 60s, the average man gained nearly 30 pounds, and the average woman gained over 25 pounds. This is, compared to others, 30 pounds heavier than the average Frenchman and over 40 pounds heavier than the average Japanese man, which I think highlights the issue with obesity. It is worth noting that the average man and woman did get roughly an inch taller since the 60s, but that alone does not account for over 20 pounds of weight. So I thought it was important to go through some of the more quantifiable risks as well. On the left are just some examples. Heart disease, you have a 2 times the risk of cardiac failure. 14% of all deaths from cancers in males are attributed to obesity, and 20% females. The relative risk for males of type 2 diabetes is 42 times higher, and it's 93 times higher for females. We see an increasing prevalence of arthritis. And then on the right, we just see a more global picture, whether it be abnormal lipid profiles contributing to that cardiac failure or high blood pressure. We see gout or liver disease or pancreatitis, or just sleep apnea and snoring leading to worse quality of life. So I've mentioned obese or overweight, but I haven't yet defined those, and those definitions are coming from the body mass index. So you can see here, basically you can use someone's weight and height to compare the excess weight that they have. So if you're going, say, 5'11", roughly 195 pounds, that would put you at BMI between 27 and 28. Now, if you went down to 72, but at the same 172, but at the same height, that would place you at 24. And so it tells you the relative mass to height ratio. Now, it's important to note that the label such as overweight or obese is not actually a direct measurement of excess fat. It's a surrogate. It just means you have that excess weight. It does correlate to body fat and then future health risks, and this is important at a population level for health. But it's not totally consistent. It's influenced by a whole bunch of factors such as age or sex or ethnicity or muscle mass. Someone who has a high muscle mass may very well weigh to the point where they're in the obese range, but yet will not have those same risks associated with excess fat. There are other measures for weight and height. Waist circumference is a popular one. It's a distribution of body fat versus the amount of fat. And so in this case, you measure the circumference around the waist, and so there are other ways to measure weight and health and body fat composition. The standard, but certainly costly option that won't be available to all patients is the DEXA scan. It uses X-ray absorption to measure the composition of your organ tissues, your bone mass, your muscle mass, and your fat composition. In addition, there's skin calipers, so these will measure visceral adipose tissue. It's effective for measuring body fat percentage. You do need to be trained how to use them, but otherwise it could be an accessible option in the office. And then finally, you have the bioelectrical impedance analysis. These are handheld units most of the times that measure electrical conductance of different body tissues and then uses that to predict body composition. There is evidence that suggests these are accurate and good to use in the clinic. Others say that they're inaccurate, but overall, they tend to overestimate the body fat composition in lean individuals and then underestimate body fat composition in obese individuals. So we're going through these terms. We're discussing the risks of obesity, but we haven't really discussed dieting yet. And so we're going to go over a few different ways to counsel, or really just tools that you can use to help along. It's typically regarded that the 5 A's are an effective way to counsel for making those dietary changes and helping with weight management. We do have another video that goes through counseling methods like the 5 A's, so I recommend checking that out. And then for your patients who are still somewhat resistant or perhaps not yet motivated to change their dietary habits, you can always use motivational interviewing to help the patient develop some discrepancies and help them build up their motivation for the long term. Again, both techniques are found in our Intro to Counseling video, and I recommend checking that out. As we consider diet changes and weight management, I think it's important to ask, what do we consider to be a balanced diet, or what's balanced nutrition? And on the right, I have a little graphic from the USDA that shows the evolution of nutrition guidelines from the 1890s when it first started. And there's been shifting emphasis on what's important over time. Initially, it was about just eating enough and getting enough nutrients. And then we had influence from World War II, rationing in the 40s. And then all the way up into the 90s, where perhaps a more familiar food pyramid came about. And then finally, what we use today is choosemyplate.gov. So over that time, there's been a lower and lower emphasis on things like dairy products and meat, particularly red meat consumption. And with the MyPlate guidelines now, there's a larger focus on whole grains and fruits and vegetables with every serving. I placed a link to myplate.gov both in the syllabus and on the slide here, and I recommend going through those for your own education. But now we might have patients that are aware of these changing guidelines, and so I think it's just important to note that it does change. It may very well change, but continue to change. But we're providing advice based upon what we know in the moment and based upon the data that we have, and so that the recommendations we do make are the best recommendations we have at the time. As you go through the nutrition guidelines, like myplate.gov, you'll notice that it's dependent upon a lot of different factors, and so there's no one easy answer to say how many servings of fruit should you have in a day, or what's the best whole grain for you. So those factors can be dependent upon age, weight and height, activity level, and the sex of the person. And so what I placed down here, and you can also find it with myplate.gov, is a calculator to help determine your dietary recommendations per day. So you can type in all those various factors and get an output that says someone at your age, height, weight, and activity level should have about this many calories per day and have this many servings of proteins, this many servings of fruit. And I think it would be helpful to walk patients through that to give them the idea of what's appropriate for them. So this table here is from the Dietary Guidelines for Americans from the USDA, and it goes through the different food groups and subcomponents of those groups based upon your calorie level per day. So say if you were at 2,200 calories per day, you're looking at roughly 3 cups of veggies per day. And then it goes a little further to say, well, you should have about 6 cups per week of red and orange vegetables and 2 cups per week of beans, lentils, and peas. And it gives you a relatively comprehensive breakdown of what your diet could look like over the week and day based upon your calorie requirement. So how do you get to your calorie requirements? So the myplate.gov and the DRI calculator will both give you what's called your BMR, so basal metabolic rate, which is basically how much energy is expended at rest. Now, this is broken down by sex between males and females, but also has a bunch of variables such as muscle mass, age, genetics, environment. So the temperature of your environment, you're going to burn more calories trying to keep cool and keep warm. And then what's your diet, whether or not you're pregnant, and then different supplements that you take. So here's the calculations just so you can see them. But I don't think you'll ever be calculating them out. There are multiple different calculations. This is one of the more standard ones. And so once you have your BMR, that gives you an idea of how much energy you need to just sit in a chair all day. And then from there, the myplate.gov and the DRI calculator will give you what's your likely expenditure per day, including your activities. And that gives you an idea of how many calories you need to eat to maintain your weight. It's worth pointing out that based with your BMR, calories in equals calories out, meaning to be, I guess, reductive, if you're trying to lose weight, it's typically recommended that you run at a deficit, meaning that if you're incredibly active, you may be closer to your BMR rather than what your total energy requirements are, so that you're running at a deficit, so that you're not putting in more calories than you need, so that your body then has to burn the fat in order to meet those demands. So now I thought, since we've went over BMRs and we've went over the different nutrition guidelines, that it would be good to go through a few different diet plans. And in this case, diet plans are really just different lifestyles of eating and activity that can help you prevent weight loss or prevent weight gain, help lose some weight, or help improve heart health or mental health. So the first one is the Mediterranean diet, and if you look based off this food pyramid, that there's a large emphasis on fruits and veggies and whole grains and nuts, legumes, and seeds. And then some emphasis on seafood, maybe 2 times a week, and then a low emphasis on poultry, so chicken and turkey, or eggs or cheese, dairy products, and that you're primarily looking to drink water, some wine in moderation, and then every now and then some meats and sweets. The Mediterranean diet, there's a few of them. It may help slow down cognitive decline in older adults, and so this can include Alzheimer's disease. So it may slow down the progression from cognitive decline into Alzheimer's disease. It's associated with reduced risks of developing cardiovascular disease and type 2 diabetes. And like I said before, it focuses on fruits, vegetables, and whole grains. But if you're talking to your patient about this, you might want to advise them to watch out for excessive calorie consumption, since the Mediterranean diet by itself doesn't really emphasize portion sizes, rather just the relative frequency of the foods. you would want to use this with something like myplate.gov to really focus on here's what a portion size should look like, and here's the frequency within those portions. So in addition to the Mediterranean diet, we have the DASH diet. This is a diet meant to stop hypertension, so reduce blood pressure. And if you look, it has a similar emphasis on whole grains, on veggies, um, and legumes. And you see that things like sweets and fats and oils um, and meats are on the lower end. With the DASH diet, you can see impact is a little 2 weeks. A meta-review study found that the DASH diet had, for systolic blood pressure, the top blood pressure, the higher number, that it typically reduced blood pressure more effectively than a fruit and vegetable diet and both control. And so we're looking at a difference of roughly 4 millimeters mercury to 12. And then the tips here include, well, trying to cut out salt. So using salt-free spices, not adding salt when they cook, adding in more veggies, adding in more lean meat, and then choosing the low sodium or the no sodium options for something like canned vegetables or canned beans. Now, if the DASH diet and the Mediterranean diet sounded interesting to you, then you should also consider the MIND diet, which is effectively a combination of the two. And we're still seeing the similar patterns of more whole grains, more vegetables, less emphasis on meat and cheese and sweets. So with the MIND diet, like I said, it's a combination. It can help slow the progression of dementia. Studies have seen that Alzheimer's disease has a lower risk between 30 and 50%. It focuses on natural plant-based foods, so showing again that it's really not focusing on meats. As opposed to vegetables, there's a larger emphasis on dark leafy greens, and for fruit, it's a focus on berries rather than just fruit in general. And this is based upon the antioxidants that are found in both. So moving away from the diets based on food, here we have intermittent fasting. So intermittent fasting is a method where you fast or you don't eat based upon different patterns. So there's an alternate day pattern, meaning every other day you effectively fast for the entire day, which means you can still have things like water and coffee and tea as long as they don't have calories with them. There's a 5-2 fasting period where 5 days are normal and then 2 days of fasting. Or you can have a daily restricted fast. So this means perhaps from when you wake up until about noon, you don't eat. And then from noon to 8, you eat as you need. And then from 8 p.m. until when you go to bed, you restrict your eating as well. It's been shown to be as effective as a low-calorie diet for losing weight, meaning that all things being equal, you lose roughly the same amount of weight as if you just restricted your calories. But there may be some additional help reducing inflammation. So inflammation in this case might be seen in improvement with arthritis, asthma, and then the risk of stroke. Now, there are also some side effects with this type of diet modification. You may obviously just be hungry since you're not eating for periods of the days or days on time. And because of that, you may also have fatigue or some insomnia or nausea. Typically, hunger will go away over time as your body adjusts, but it's worth noting, especially if you're going to recommend it to patients. And then finally, we have the ketogenic diet. So this is a diet that relies on little to no carbs in the diet at all, and forcing the body to rely on the production of ketones in order to supply energy. And so the ketones are then being derived from the adipose tissue. And it takes between 2 and 3 weeks to enter into ketosis, so you may not see results that quickly. But over time, it reduces appetite due to that high fat and protein consumption. Relative to other um, diets, you see that a relatively stable BMR, meaning that as you continue some diets, the amount of energy the body needs may go down, but in this case, it stays stable, meaning that you'll see more and more weight loss, and then it may help prevent cognitive decline, similar to the um, Mediterranean and Mind diets. The thing to look for is that some chronic conditions like renal disease need to be closely monitored um, to make sure that we're not putting excessive stress on the kidneys. Some basic pearls, little bits of wisdom to give to patients in regards to weight management, maybe to help motivate them more. Um, First, just recommend reducing sugar consumption across the board. People may ask, well, what types of sugars? High fructose corn syrup gets a lot of attention, and there's mixed evidence as to whether different sugars are metabolized differently and lead to higher consumption just of calories over time. But we can still broadly say that increased sugar consumption is not effective for weight management, and so to avoid things that have added sugar or that are primarily sugar. In addition, weight loss, to help with motivation, weight loss can lower HA1C, which is a measurement for diabetes status. So a 5 to 10% weight loss can reduce the H1C by up to 1%. It can also lower mortality rate. So if you lose between 9 and 13 kilograms, you see mortality rates drop by 25%. And then again, just that same minimum weight loss of about 5 to 10% can lower blood pressure with the DASH diet even further in general by 2 to 3 milligrams, which is, or millimeters, sorry, of mercury, which is still helpful. On the right are just some dietary changes that can help kind of spur that. So if you have a patient who frequently eats fast food, rather than say cut it out completely, you can maybe challenge them to decrease how many times they eat fast food by 1 time a week and continue to work on that. And that maybe they can replace that one meal with something cooked at home. Or if they're trying to eat more vegetables, you can say try to increase just by 1 serving a day and change over time. So in addition to just helping their motivation, I wanted to point out that diet apps have been found to be very helpful. The few that I just have kind of showing on the right are MyFitnessPal, Noom, and MyPlate.gov also has its own app. Not endorsing any of them in particular, but broadly, diet apps have been shown to lead to healthier behaviors. So increasing the consumption of fruit and vegetables, choosing low-fat products while avoiding sweetened beverages, and then more closely adhering to the calorie recommendations based upon um, the person's height, weight, and energy demands. And then overall, when using diet apps, you have a higher probability of losing weight over a 12-month period. So it seems like something beneficial to recommend to any patient. Wanted to say that there is a lot that goes into nutrition counseling, and that there's likely no best answer for any patient. This lesson is not meant to be totally comprehensive, but rather a jumping off point for both you and patients. Please look at the resources in the syllabus to look into the particular details of certain diets or to address issues like which foods to avoid. Thanks for listening.